So it's good to see all of you here this evening. I think we'll get started. It's my first time here at the Goodman Center. We're thrilled to be here in this new place. It's much more cozy than the other one. I like that. Anyways, for those of you that I haven't had the opportunity to meet, I'm Laura Bouillon-Dent. I'm one of the UW Neurology Movement Disorders doctors. I'm also the director of the Clinical Movement Disorders program. And I'll be the one talking to you tonight about early Parkinson's disease. Before that, though, I'd like to get a few introductions and a thank you in. So as many of you know, along with this new place that we're having for our talks, we have some new people that have joined our group because unfortunately, Nancy, our nurse practitioner for many years and the key developer of this program, has retired, and she's here tonight. And we just like to publicly thank her for all that she's done. These are for you. More flowers. Yeah, I've given Nancy flowers many times this past month. It's been really fun as we've celebrated all of her accomplishments at UW and all of that. So thank you.
It's a privilege, and it's always delightful to see this many people here. So kudos to you for taking the time. And the people who bring you here are wonderful people. So thank you. It's been a privilege.
So not that we can ever replace Nancy, and she's still going to be hanging around, hopefully, but it's led us to have the opportunity to have somebody new join our group. And so I would like to introduce you to Addie Gasper. She's a nurse practitioner who's going to be joining us, and she'll be seeing patients in the clinic, doing DBS programming. She's going to be involved in the moving forward things. So, we're moving forward strong. So I'd like you guys to all help me welcome Addie to our Parkinson's community. So now on with the show. So as many of you know, I'm not always the greatest with multimedia things. Not that this is multimedia, but what I hope to do tonight is to talk to you and give you some of the insight that I've learned over the years in when I'm diagnosing Parkinson's disease and talking about early on in the course of the disease. What I'm hoping to do is to be able to go through some of the maybe basic science to give you some understanding, how we go about diagnosing it, some of the concerns early on in the course of the disease. And then I'd like to open it up and, I'll be giving you some advice or some ideas of things that I've been taught over the years by my patients. And then if there's any of my patients or anybody in the audience who is experienced that would like to share their advice of how they coped early on, that would be greatly appreciated. So we'll get going with all of this and make sure I'm pointing the right, yes. So Parkinson's disease is named after Dr. James Parkinson. He wrote this essay on a famous essay on a shaking palsy in 1817. And so he was the first one to really describe well the syndrome of Parkinson's disease. And so he gets awarded with us calling it Parkinson's disease. Before that, there were other names for it, but as many of you might know, it's an age-related neurodegenerative disease. And the average age of onset is somewhere in the 60s, but the age range can be anywhere from early adulthood through early 90s. There is a rare juvenile form of it. I've never, thankfully, had to see that. At least 1 million people in the US are afflicted. 60,000 or more cases are diagnosed each year. And we see more and more of it because people are living longer and because we're better at identifying it. So Dr. Charcot was a famous neurologist in the mid-1800s, and he has this famous drawing, at least in neurology nerd circles, showing somebody with Parkinson's disease. And he was one of the first more modernish people, too, who distinguished Parkinson's as its own disease entity, even though he didn't call it Parkinson's disease. It was often called paralysis agitans or the shaking palsy. Anyways, but he started to differentiate different subtypes that we still recognize today. For example, some people never have tremor, some people do. There's some atypical forms of Parkinson's that are very classic as well. So when I'm trying to diagnose Parkinson's, I'm looking for 4 cardinal features. And this is something I even teach the medical students and such. So there's a lot of features of Parkinson's that we'll go through, but there's 4 things that I'm trying to see if there's a few of these things. If I'm doing research, there's very strict criteria about how many, depending on the study, how many things you have to have. But so one of the things I'm looking for is something called rigidity, and that's a certain stiffness in the limbs and the trunk. There's bradykinesia, which is a medical term for slowness of movement. There's resting tremor, a specific type of tremor that we may see. And then there's postural instability, where people aren't able to kind of adjust themselves in space if they're moving around, and that leads to them falling. So here's a gentleman with a classic resting tremor of Parkinson's. Many of you have seen this video before, but you can see it's a high frequency tremor. There's a pill rolling component to it in his left hand. And it's occurring in his arms when his arms are at rest. So it's resting on his lap, so he's not using them to do anything. In distinction from people who might notice, when I'm eating or something or writing, I'm having a ton of shaking. And sometimes tremors can be hard to categorize too. So bradykinesia we test by looking at finger tapping, foot tapping, and just looking at the amplitude and the character of the movement and how quick it is. And then to test for rigidity, we move a limb through its range of motion, and we feel some resistance, some abnormal resistance, almost like the person isn't relaxed. And sometimes we do different things to bring out that rigidity, or to see, to double check it. You can also see this gentleman's got a nice, I think a nice resting tremor. So those are some of the key features that we're looking for. And these are like some classic teaching shows that we show like the students and whatever. So all of those things are related to the so-called motor symptoms. And and motor is referring to the ability to move, essentially. Now, many people will also have other signs and symptoms, none of which are totally diagnostic. I mean, we're looking for a constellation of signs and symptoms. That, the only thing that's almost completely diagnostic on its own is if someone has a very classic resting tremor. So not everybody will get all of the symptoms, and they'll get them to different severities. So there's a wide spectrum. That's one of the major themes of this, a very wide spectrum of severity, progression, and a lot of variability. So some people will develop a masked face, meaning they lose facial expression. So they might look angry when they're not, or they just are looking like they don't understand you. Micrographia refers to small handwriting, and it can be really, really small. Even if you try to imitate it, you can't do it. It's like that teeny tiny, and sometimes it's legible, sometimes not. Because of the bradykinesia, or slowness of movement, it will take people with Parkinson's a really long time to do their usual activities. It'll take them an hour to get ready in the morning instead of 20 minutes or something like that. They often assume a very classic posture with being bent forward, a stoop posture, and having a shuffling gait where they take itty-bitty steps. They might not swing their arms when walking, and then they'll have difficulty doing often like things we take for granted. Standing up from a chair will be difficult. Turning over in bed might be difficult. And then also their speech might become very, very quiet. So here's another classic teaching movie of a woman who shows many classic signs of Parkinson's. She is not on any medication, and so you can see her tremor. If you look real close, her legs are shaking too. So the tremors might affect the arms, they might affect the legs, or some people will have no tremor whatsoever. Her tremor is a little trickier to figure out because she has a resting tremor, but also a postural tremor when she raises her arms up. So she's just doing some maneuvers kind of to show off her tremor. In a minute, she's going to stand up and walk for us, and you'll see more of the classic features. So she's going to grab onto the chair in just a second. There you go. And see, as soon as she's using her hands, that tremor disappears. The tremor from her legs disappears as she's moving to try to stand up. Takes her a couple times to try to stand up because of the Parkinson's. And you can just see how she's moving slowly. I mean, she's actually trying to move as fast as she can. As soon as she lets go of the chair, there comes that resting tremor back. And you can see her posture. She's being told, stand up as tall as you can. And that's as tall as she can go. And you can see the itty-bitty steps that she's taking. And then her tremor's doing all these different things. And you almost get the sense if you just happen to walk by her too fast, she might tip over. And so now she's asked to turn, and because of the loss of her postural reflexes, she has to take a whole lot of little steps so she doesn't topple over. So there we go. All right, that's enough of that one. So those are the motor symptoms of, at least some of the motor symptoms or movement symptoms of Parkinson's disease. Now, people will also have a whole bunch of symptoms sometimes that we would consider non-motor symptoms. And so I list some of them here. Many people with Parkinson's will have sleep disturbances. It might be sleep fragmentation where they can fall asleep and only stay asleep for a few hours at a time. They might have what we call REM behavior disorder, where when they get into deep levels of REM sleep, which is our dream sleep, they start acting out their dreams and they have dream reenactment and such. So, and if their sleep is disrupted enough, they might then be sleepy in the morning, during the day. There's a part of our nervous system that will control what we consider automatic types of things like our blood pressure, heart rate, bladder, bowel control, our GI tract. That's called the autonomic nervous system. And people with Parkinson's may have disruption of that part of the nervous system as well. So oftentimes people are generally constipated, and they might have the hyperactive bladder where as soon as they have to go, they better get there quick or else they'll leak. Their blood pressure, orthostasis refers to low blood pressure when you stand up. So normally when we stand up, our heart rate increases to compensate for the change in position and to keep blood going to our brain. But some people with Parkinson's, that system is kind of sluggish, so they might get really lightheaded, as if they're going to pass out. And then some people have drooling. That's what sialorrhea is. We always have to have a fancy term in medicine to make it sound cool. But people with Parkinson's don't produce more saliva, but they just don't automatically swallow as often, just like they might not blink their eyes, which contributes to that masked look sometimes because they just don't blink as often. They also don't wiggle around. Like up here, I'm kind of dancing around, partly because I'm excited, but most people kind of move a little bit. But if you see someone with Parkinson's, oftentimes they look very calm and relaxed and almost statue-like because they just don't fidget like the rest of us do. People often will have mood disorders as well. And one common misconception, if someone's having worsening depression or anxiety, they'll notice this, or they'll notice their movement symptoms of Parkinson's worsening. They'll be like, oh, well, of course I'm getting depressed. My Parkinson's is worsening. If you fix my Parkinson's, I'll stop being depressed. When in reality, it's actually the opposite oftentimes because of some of the chemical abnormalities. People with Parkinson's have a risk factor for developing depression. Now, certainly people with Parkinson's are sad and they get frustrated, and there's a grieving process that goes on, but that's not necessarily clinical depression. So we monitor for clinical depression and clinical anxiety very carefully because it really affects the quality of life. I've had people who have had worsening depression and they feel their motor symptoms worsening. We might adjust their medicine some, but once we get their mood under control and the depression lifts, we can actually cut back again on the medications. So it can have that dramatic of an impact. I wish there was a different term for clinical depression because, depression, we all experience that as a normal part of our mood variabilities, but when you have clinical depression, it's much worse. Some people with Parkinson's will have memory impairment to varying degrees. Some people will just notice a slowness of thinking. Other people will develop outright dementia. And the numbers in that will vary depending on the sources and how they actually define dementia. And then some people can develop some psychotic features. And by that, I mean they might develop visual hallucinations, they can develop paranoia, they can develop some delusions. These are usually very late features of the disease, and it can be the disease or sometimes it's the medicines causing this. And currently, for the past couple of years, there's been this terrible commercial on TV showing people with Parkinson's and these terrible hallucinations, and they make it seem like people with Parkinson's are insane. And that is not the case. Even if they're having these hallucinations, they're not insane, you know. But it's a very, very damaging commercial. But anyways, but we can often handle that.
It also implied that everyone with Parkinson's was going to have.
Right. And that's one of the golden rules, if you will, of Parkinson's, is that not, everyone is different. Not everybody gets everything, which is, when you're reading stuff, it's, something to keep in mind. There's tremendous variability. And I'll keep repeating that. You'll get tired of me saying that. So what happens when I'm diagnosing? Like you come to the office and that sort of thing. So first of all, everyone's frustrated because there isn't a blood test that diagnoses Parkinson's disease. Everyone wants that test. Well, really, the test is coming to see an experienced neurologist or a movement disorders neurologist, having us hear your story of symptoms, let us do our neurologic exam, and then we'll diagnose you. That is, to this day, the best test for Parkinson's disease. And it truly is a test, in my opinion. You don't need numbers and pictures, and there's a lot to be said for that. When I meet somebody, I want to hear their story of what they've noticed happening to them. I like to hear the family's input too. Do I necessarily care about the neurologist they saw before, what they thought? Not really, because I'm going to make my own decision. And any good neurologist or movement disorder specialist is going to do the same thing. You make your own diagnosis. And then we do a neurologic exam, which is a bunch of maneuvers, all painless, some of them kind of weird, but it's all geared at, for me, trying to figure out which part of the nervous system is impaired. So there's all kinds of muscle testing and things that I'm doing, and what I'm trying to figure out is which part of the brain or spinal cord or peripheral nerves is not working right, and that helps me figure out what is wrong with the individual. So those are really the most important things. Some family history is now interesting to get as well, because sometimes Parkinson's is now, we know there's a genetic predisposition, but that's not going to make or break the diagnosis. Sometimes, depending on what I'm hearing, I might get some blood tests to look for other things. For example, if someone has a really bad tremor, I'll want to make sure their thyroid function is okay. I'll also be looking at their medication list, their other health issues that they have, to see how it all fits in. Because sometimes, for example, people have some pretty bad arthritis, and that will affect their movement. They'll be moving slow because they're in pain from arthritis, not because they have Parkinson's, or maybe it's both. So it really, takes somebody to really look at that individual to figure it out, because there can be some confounding things that are occurring. And then there's brain imaging, which is always fun to get from my perspective, because I like looking at the things. But really, the reason to get it is to rule out some other things. And I'll talk a little bit more about that. So despite all of our fancy technology in hospitals these days, we still make the diagnosis of Parkinson's disease based on clinical history and the exam. So, and that's a valid test. So there's some weird terminology, not weird, I say everything's weird, I'm weird, but you'll hear different terms. And so there's Parkinsonism, then you'll hear idiopathic Parkinson's disease, you might hear atypical Parkinson's and Parkinson's plus syndromes. So the garden variety Parkinson's that most people have is the idiopathic Parkinson's disease. Now, any good neurologist is, so that's what most people have, and that's almost what we assume you have until proven otherwise. But in all the subsequent visits, your neurologist will be, taking a look at you and kind of in their mind reinforcing that diagnosis or seeing, oh, are other things developing? Because there are a few disease entities that start out looking like idiopathic Parkinson's disease, but it really is the early signs of one of the atypical Parkinsonian disorders. And that's what I'm listing, at least the first 4 things here, even all of them. So they're the less typical, they're the non-idiopathic ones. And sometimes if the neurologist isn't quite sure which way to go, they might kind of fudge and use the term Parkinsonism. So Parkinsonism is like this really broad term. And under that, there's the more, there's idiopathic Parkinson's disease, all of these atypical Parkinsonian disorders. An old term is a Parkinson's plus syndrome. That's an atypical Parkinsonian disorder. And some things over the years get renamed and recategorized based on how we learn more things about it. So the role of neuroimaging. So as I said earlier, I may or may not get pictures of your brain. And so sometimes you might get a CAT scan or an MRI. The standard CAT scan and MRIs that we have today should be normal in somebody who has idiopathic Parkinson's disease, and even most of the atypical Parkinsonian disorders. So there's nothing on those scans that's going to tell me whether or not you have Parkinson's disease. They'll be age normal, yet the person I'm examining might not be age normal. So that's just a picture of the brain. In the future, there might be better MRIs. There's lots of research going on, even at UW. One of my colleagues does a lot of imaging research, trying to find better ways to look for it, to verify and help distinguish these different disease entities. But right now, CTs and MRIs should be essentially age normal when you have Parkinson's, idiopathic Parkinson's disease. And so those are pictures of the brain. There's some more functional types of scans trying to look at brain activity. And those are fluorodopa scans and DAT scans. And the use of those are really pretty controversial. They're sort of newer scans that are available, but yet they've been around in research for decades and have been a bit disappointing. So, most neurologists don't need to get a DAT scan to diagnose it. And a DAT scan has also, in my practice, when others have ordered it, because I've yet to order one, maybe I'll need to someday, but they can come back normal, even though the person has clinical Parkinson's disease. And sometimes I've had a few patients where like a spouse was tested too, and theirs was abnormal, yet they looked normal, and I don't know, maybe 10 years from now she'll be abnormal, I don't know. But anyway, so it's not 100%, but you think it is because you see this picture. That's just how our thinking is. So you don't need those, and often insurance companies don't pay for them, and it's the one time I'll say, oh, thank goodness they won't pay for them because they're really not necessary. Alrighty, so what in the world is happening to that brain of the person with Parkinson's disease? So here, this is a diagram, of course, showing the brain as if you're probably looking like this is the back of the brain, their eyes would be on the other side of the screen, and this is the brain stem down here. And in one of the problems with Parkinson's disease, one of the main things is right here in the substantia nigra. Right there is where these brain cells, neurons that make a chemical called dopamine are. And those brain cells are dying off for reasons we don't completely understand. And so those brain cells communicate with these centers of the brain called the basal ganglia. And the basal ganglia is involved with helping us control our movements. So people with Parkinson's, their muscles will be strong, very strong. But it's the circuitry, almost like the computer program, if you will, that doesn't work, that has some glitches in it. So even though they have strong muscles, their joints are okay, they just can't move, and they get stuck and they're slow, and it's like they don't have full control of their limbs. They will look much different than somebody who, let's say, had certain types of strokes where like the cortex of the brain is more involved. Those people will have what looks like more true weakness and even atrophy, like shrinkage of their muscles and stuff. I mean, people with Parkinson's over time can look a little atrophied, but for the most part, their strength is really good. The problem isn't in the muscle, it's with the signal to those muscles of how to move and work. So to continue on, almost like you're in a mini med school, here's some pictures of the brainstem showing the substantia nigra again. So this is if you cut your brain across like this, and this is the substantia nigra where those dopamine neurons are living. And this is someone who did not have Parkinson's at the time of death. And this is an equivalent section from someone who did have Parkinson's. And you can see the obvious loss there. It's even shrunken across there if you look closely. So autopsy studies have shown us that by the time someone is showing the movement abnormalities of Parkinson's disease, they've lost 60 to 70% of the brain cells in that area. So that's a lot of cells gone. So your brain is always compensating. It's built to compensate. But of course, at a certain point, it can't compensate further. And so that's when some of the symptoms will start showing through. Some people, if they have Parkinson's for many years, and once they pass away, and if we're able to, no matter what they pass away from, if we're able to look at their brain, they'll have over 90% cell loss in that area. So that's one thing that's happening to you, to the people with Parkinson's. And then if we look under a microscope, if we take some of that tissue and we put it under a microscope, we see things called Lewy bodies. You always hear about Lewy bodies, and here's a Lewy body here. There's another one, where is it? Over here. And these are these little red circular things. And what that is a mutant protein that's accumulated and caused, we're not sure if that's one of the causes or if it's just a byproduct of Parkinson's. But there's a lot of research going on a protein study, mutant alpha-synuclein, looking to see, is it the thing that's causing cell death, or is it just kind of like a byproduct of the degeneration? Okie dokie. So what's causing Parkinson's? We still don't know. We do know there is a genetic predisposition. And then we think other things have to happen to trigger it. And those things might be different depending on the individual. It might be that 3 things have to happen, or 5, or 1. We don't know. But these triggers, some of them that when they do big population studies, they're seeing, maybe environmental exposures. We do know that certain pesticides seem to maybe increase your risk of Parkinson's disease. We see a lot of Parkinson's in teachers and healthcare professionals who get exposed to infectious agents a lot. And so we think, is there an inflammatory response? Other toxins, other things we don't even know. So the list goes on and on and on. So that leads me to talking about, neuroprotection. So, all these cells are dying off and we don't want them to. Is there anything we can do for that? And so far, we don't have any medicines or agents you can ingest that will slow down that disease process. However, there is some promising research that shows that exercise might do that. And so currently our preventative treatment is exercise. There's some thought that by the time we are discovering Parkinson's and people are symptomatic, like I said, 60% or more of the cells are gone. So it might be that with our current ways of figuring out Parkinson's, we're already a bit too late for some of those preventative things to work. That's why there's tons and tons and tons of research looking for earlier markers, or what they call biomarkers, to see if we can find things further, and then maybe some of these things that theoretically should slow down disease progression, if we start them early enough, maybe they'll actually work. But exercise seems to really, have a huge impact and you can think of lots of reasons why exercise is good for all of us, right? But there's some animal work showing that, when they can force an animal to exercise and then look at their brain, the ones who are forced to exercise seem to lose cells at a less rapid rate than those who don't. So, all right, so what's our treatment for all this? So the current traditional treatment is exercise, and then we have some medications that can help with some of the symptoms, and then in certain cases, surgery. Now, when you're first diagnosed, well, gee whiz, it's really the exercise and the medications. Nobody needs the surgery early, at least at this point in Parkinson's history. So the exercise, there's quite a wide variety of exercises available, which is, to me, who's not particularly an exercise-friendly person, I have to really force myself you know, I'd like to have lots of options because I'm not one of these people who just enjoys exercise. So, you know, most patients will say, well, find a type of exercise that you enjoy, you know, and do it several times a week. Not every day, you know, but, you know, 3 times a week or something like that. You do want to work up a sweat a little bit. You know, it's not like you go for a walk and it's leisurely and, oh, isn't that tree pretty? I mean, you do want to get your heart rate going. But, you know, there's a wide variety. There's no one right exercise for everybody. And again, there's no one right way to live with Parkinson's. And so you have to find your way if you have it. It's interesting, you know, how exercise goes in fads. You know, there's like cycling comes around every 5 years as like, oh, forced cycling is the big thing. And then now it's the boxing classes, which are awesome. And, you know, and it's not that it's the boxing itself, it's the whole program that people are entering that helps them, at least in my opinion. And so the physical therapists, right, they have to justify to Medicare and whoever else is paying for them that their program is worthwhile. So there's a new exercise fad, they'll come out and they'll, you know, study it in people with Parkinson's. So there's the group that does the exercise, the new exercise, and the group that doesn't. And every time, no matter what fad exercise it is, the group that does the exercise will score higher on all of their rating scales and stuff. So, you know, it's like they're just get moving and keep doing it. If your exercise is boring, well, find a different one. Easy to say, right? Now, it's hard for people to start exercising, right? And especially you're having movement problems. So sometimes it's a good idea maybe to even see a physical therapist so that you can start a safe exercise program, because there's nothing worse than not wanting to exercise. You go and do it, you strain your muscles, and there's a good reason to never do it again, at least if, you know, in my book. And so, you know, sometimes going to a physical therapist early on is very good. In fact, the therapists get mad at me because I don't send people soon enough all the time. So, and that's, you know, there's therapists that are, physical therapists that are trained specifically in Parkinson's, but every physical therapist in their education gets exposed to people with Parkinson's disease. So even, you know, if you're out in the middle of a small town or something, you know, there's a physical therapist, chances are they know some things that you can do to help yourself. So, all right, now moving on. Whoops, did I press the wrong button? That's been known to happen. All right, so medications. Yes, we do have some medications. As I told you earlier, one of the main things that's missing in the brain when someone has Parkinson's is dopamine. And dopamine is a chemical that helps the brain cells communicate with each other. It's called a neurotransmitter. And so since the brain cells are dying off that are making the dopamine, this messenger is not there enough. And so when it gets too low, you start to have some of the symptoms and the movement symptoms. So the tremor, the bradykinesia, the slowness, the stiffness, the rigidity. And so all of our medicines are geared, for the most part, at trying to raise the dopamine levels in the brain. And the things that will get better can be the tremor. Some tremors don't respond, but tremor, the stiffness and slowness are the things that will get better. Not all symptoms will get better with the medications, and that's a key thing to keep in mind. And one thing that I'm keeping in mind when I'm seeing people in the clinic is our target symptoms, something that's going to respond to the medicines. Because all too often I see that someone came from somewhere else and, oh, they've been, you know, they're on these high doses of medicines, but yet they still can't move. And it's like, well, it's because, yeah, the medicine is, you know, it didn't help you with that symptom, and now you're over-medicated. So it's, again, you know, it's always a balance and juggling act. And it will always change. That drives people crazy because it always changes. You know, what works, I mean, and that doesn't change. Some people changes daily, but for the most part, you know, especially early on, it'll be like, oh, this works for, you know, a few months or a few years, depending. And then, oh, we have to change it, you know, and so that's kind of how it is. So my initial quote, the only constant in life is change, is really fits in here. So what I spend most of my time doing with patients is, you know, making sure they have Parkinson's disease, or if not, one of the variants or whatever. I hear their symptoms, and I'm trying to figure out, can I do anything to help those symptoms? Are they taking care of themselves? Are they getting some exercise? Are we addressing their sleep and mood? And, excuse me, if I do have them on medicines, I'm checking to see Is the symptom that we're targeting with that medicine improving? Is that the right dose? Are they having side effects to the medicine? All of those things, and those things can change over time. So that's why I can spend all my day seeing people with Parkinson's, and they're all highly different, and I cannot get bored. So even though people are like, how can you see the same thing every day? It's like, but it's not the same thing, So, it's all about your doctor, right? So here's a list of the medicines available today. Some of them I use more than others, and I'm not going to go through, this isn't a lesson in pharmacology, because then you would definitely fall asleep. But the one I just wanted to mention, our best medicine to this day is carbidopa-levodopa. It became available in the 1960s and revolutionized the treatment of Parkinson's. Prior to that, once you were diagnosed with Parkinson's, you would live about 10 years, and then you would die in this like rigid state. Now people's lifespans have normalized nearly, depending on all their other health issues. They can move, their quality of life is good. It's not a perfect medicine, but it's not something you have to be afraid of. But it does take, some skill to use it and to make sure you're on the right doses and that sort of thing. It does have a potential long-term side effect of developing something called dyskinesias, which are these wiggly movements. And people may or may not get those. Then they might get them mildly. They might get them severe. We don't know. So sometimes you might see us, maybe not starting with that medicine right away, especially if you're a little bit younger onset. But it's not a bad medicine. It's not a poison. It doesn't make your disease progress quicker. It does not wear off. The effects of it don't wear off over time like a pain medicine. If you take too much pain medicine, you develop a tolerance to it. That doesn't happen with levodopa or any of the medicines, but you do have to increase them over time, unfortunately, because the disease is progressing. So anyways, there's a big, to me, there's a big difference between that. So anyways, but there's this whole slew. There'll be more. They're always coming out with more, but still, like the newest one I have on here, it's called, I'm going to say the name wrong, Imbrija, something like that. It's, whoops, let me get my this guy. And it's an inhaled version of levodopa. I don't know if it's going to be that helpful for people or not. But again, another tool in the toolbox. That's what this is a toolbox. So, alrighty. Now, so when do you start medicine? Well, that's going to be different for everybody, and that's one of the things we talk about a lot. Well, geez, are my symptoms bad enough to start medicine? And it's individual. There's no one right or wrong thing again. So, I'll tell people, well, my rule of thumb is when the symptoms are bad enough. Well, that's a kind of stupid, wishy-washy answer, So it's like you have to see what kinds of things that person enjoys doing, if they're still working. What does their job entail? What are their responsibilities? What are their hobbies? And that will all determine it. Sometimes we try medicine, it makes them feel crummy, and then we decide to stop it. And, so there's a lot of, there's no one right recipe of medications. People, if they have a good response, they'll be like, yay, everyone should do this, because they want everyone else to feel just as good as they are. But that doesn't necessarily mean, so you'll meet people and all their medicines will, there might be some similar themes, but they'll have all different ones. And that can be frustrating for people, because if they're not doing well, they'll think, well, my doctor, they don't know the right combination. And it might be a little bit of fooling around that has to occur, or what one person tolerates or helps somebody, the other, it might make them sick, So again, there's a lot of, it's not automated. They're not going to be able to replace this with droids, like medical droids like on Star Wars. I hope not. That wouldn't be fun, but there's a lot of variability. That can sound frustrating, but also I've met people who take that as a little sign of hope that, well, geez, if she can't tell me that, oh gosh, I'm going to get gate freezing 100% sure, well, maybe I won't get that part so bad. Or, so there's, it's kind of how you deal with it. And I don't know, it's hard and individual. Okay. Let's get going to some of the, so there are some people we do surgery, and not usually when they're newly diagnosed. There are studies that usually every 5 years there's a new center trying to study early DBS thinking it's going to be neuroprotective. Well, they did that way back when DBS started in the 1990s. It wasn't neuroprotective then, and in 2019, there's still no evidence that's neuroprotective means slowing down disease progression. Does not cure anything. It can, for some people, in certain situations, be life-changing for the better and help them a great deal. It's another tool, but it's not something if you're recently diagnosed or in the, that you're likely going to need to worry about. And also, we do put more stimulators in people, but not everybody's going to need one. So, so there you go. If it freaks you out, it's like, good, don't think about it now, because hopefully you won't ever need one.
Do all insurance companies pay for that or only people?
Yep, for Parkinson's they do. Yep, it's not an issue. So coping, here's the big one, right? I'm fortunate because I get to meet a lot of people with Parkinson's disease, and they tell me stuff. And some people I've known for like 10 years now, and and so I've learned a lot from them. So I'm not claiming to know the exact right thing to do, but I just want to pass along some of the things that I've learned, things that people have told me. And in fact, whoops, well, that was bad. When I found out I was going to be giving this talk, I hadn't given this kind of talk in a while. And I thought, okay, what kinds of things have I learned over the years in doing this? And then I thought, well, heck, I know a lot of people, that I see every day that are, so I'll start asking them. And it was really fun to ask these people, my patients with Parkinson's, what they would tell somebody who is newly diagnosed. And so I have written down a whole bunch of comments that they told me that I want to pass on. So, but first, you need to have a team. It's not like you need a village, like they always that saying about children, it takes a village. No, but you do need to have people. And, it can be, people close to you, friends, family. Pets can be really important. I love pets, and that can add a lot. And then you need some people to help you, having a good doctor, a doctor that you trust and can talk to. The therapist will go in and out of your lives maybe, depending on what your actual need is. Health psychologist or a spiritual advisor is really good at help. Well, how am I going to face all of this? Holy cow, the future looks kind of scary, so they're really good at helping with that. And then some people will hire personal trainers to keep them exercising. And the Parkinson's community is a resource, coming to things like this. Some people are big support group people, that works. Other people know, other people want to learn about it. I mean, there's a variety of things, and you just have to find out what works for you and be okay not doing everything too. It's okay to choose what you think works for you. All right, so I think I might have covered some of this. We're going to start running out of time. Yep, the variability, wide range of symptoms, and Oh, the other thing, this is kind of more to remind me then, is that often people think that once they're diagnosed with Parkinson's, every single symptom they have affects their body is because of Parkinson's disease. And it's like, no, regular things will happen to you too. For example, if you're having chest pain, you call 911. That's not your Parkinson's. That could be a heart attack. And so when people are coming to me and telling me their thing, what their symptoms are, I'm trying to figure out, is that really Parkinson's? We don't want to miss something else. That's why you still need a primary care doctor, and because we don't want to miss something because, you thought it was Parkinson's, so they blew it off, or, it can't be helped, it's your Parkinson's. We need to really make sure that we don't miss things. And if you're starting a medicine, the golden rule is you start at low doses and you increase slowly. Most doctors know that, but not always. So this is just some things that I've observed from people that I consider to be living well with Parkinson's. And living well doesn't mean that, they don't look like they have symptoms. These are people who have a good quality of life, And actually, I've learned a lot from these people, even to apply to my own life. It's all... Parkinson's does make you have a different perspective, doesn't it? So people will, when they're initially diagnosed, they grieve, and that's okay. It's crummy to have this diagnosis. It's so grieve, it's a loss. But then at some point you need to accept it and adapt, and people do that in all different kinds of ways. People often tell me that they don't want to be a burden to their family and loved ones. Well, one way to not be a burden is accepting help. That's not being a burden, actually. That's, so I'm preaching for a little bit now, but then you guys can all join in. You can preach back at me and tell me what you guys have found to be helpful or not. And again, one size does not fit all. Find a doctor you can talk to. And when you're looking at information, the information age is a blessing and a curse. And so, find some good sources of information. Don't read everything. You don't have to be an expert. That's why you go see your movement disorders doctor. But, find a few good sources of information. I often tell people it's okay to not look on the internet. It's okay if you do, if that helps you. But it's also okay to not. And actually, one of the comments was that, oh gosh, that was just really good to know I don't have to be on the internet looking up everything. And, so anyways, there's lots of myths out there. There's lots of fads and lots of scams. And so you just, I feel protective of, people who are living with Parkinson's disease. So just be aware. And then humor helps. Oh my goodness, we laugh a lot in the clinic. I mean, it sounds kind of weird, but there are really some funny things that happen. Sad at times, but often people, and the people are the ones laughing. I'm not laughing at them. I mean, they were laughing at me oftentimes, but. So when I polled my people about what would you tell a newly diagnosed patient, I swear, everybody was like, exercise. So there you go, and there's the humor. Anyways, and then the next thing out of their mouth was keep moving. Maybe they were like sick of sitting in the clinic with me and they meant I should get moving, but I don't know, I put it up there. And then here's more of the real stuff. And I'm gonna cycle through these kinds of things. I'm not gonna read them all to you, but at this point, I guess I would like to open things up a bit for discussion and questions. One thing I do also have, I do want to point out a couple of them. The second line up there, it's a journey, not a destination. For some reason, that really hit home to me. I don't know. And travel, have fun, stay in shape. I mean, I should be doing all these things too. And don't give up. Of course, that's easy to say, hard to do. People commonly will say, don't anticipate the future, and even as people age, when, it's scary, and so thinking too much about the future, you don't want to be totally unrealistic, but, thinking about, oh, how am I going to be, 5 years from now? Ooh, that's a scary place to be. So don't think about it. It's okay to not think about some stuff. And then I also, have known some of the so-called caregivers, and that's what I wish we could change that word. I've started to not like that term caregiver because it makes it sound like, you need all this help, you're a burden, and I mean, so I prefer talking about care partner or Parkinson's partner because people often, you hear about caregiver support groups and all that kind of stuff, and what ends up happening is like, well, when I'm first diagnosed, I've taken care of myself. I'm taking care of my medicines. I don't really need a caregiver. But your loved one needs some help and guidance maybe, or a place to go to get information. Not in all cases, but but sometimes if it's a caregiver thing, they wait almost too long. And someone gave me some good advice to tell people, well, go to those, if they're feeling at sea, go to those caregiver support things sooner than later. You don't have to wait till your loved one is really incapacitated or something. Maybe they'll never become totally incapacitated, but you can go to those things sooner and they find that it can be helpful. And don't compare your symptoms to each other. So anyways, so let me just fiddle with the computer a second so that I can get this like replaying for us. And then we can see if there's any questions and all that business. I practiced this so I could do it quick, but I'll probably screw it up. And then a couple more taps and we'll be good. Okay, we'll see if it doesn't cycle through after about 8 seconds. Let me know. So what do you guys all think? Does anyone have any questions or comments that they would like to have? I have a microphone. If you want to use it, you don't have to. I don't want to put people on the spot. Okay.
Hi, my
Hi.
question is about vision, and how do you know if the Parkinson's is affecting your vision and causing, like, my husband has blurry vision.
Yeah.
And I know there's doctors that are more,
Right, you've heard about like neuro-ophthalmologists is what they're called. And to be honest, most people with Parkinson's don't need to see a neuro-ophthalmologist. But what can happen with Parkinson's, you can get blurry vision from certain medications. You can get blurry vision because you don't blink often enough, and so then your eyes dry out, and that will cause blurry vision. And some people have such dry eyes they rebound water, which again causes blurry vision. Some people with Parkinson's more commonly over time will notice that they have some double vision, and at certain distances, you know how as your eyes age, you're like, oh, I need those readers and stuff, but as they might notice, oh gosh, it's when I'm watching TV, it's kind of double at times. And that's because they when we focus on something, our eyes need to come together. And sometimes that doesn't occur so good in Parkinson's after you've had it a number of years. That's usually like a more advanced sort of thing. And so then if your eyes aren't focusing quite the same, you'll see double. And the best thing actually for that is to try to cover one eye, unless if it's happening more consistently. Sometimes the optometrists can put a prism in the lens that will help with that. Sometimes it doesn't help though too. But that's the most common eye thing. Oftentimes your neurologist will be checking your eye movements because there is one of the atypical forms of Parkinson's that will have a certain different type of eye movement abnormality. So I hope that helps. But, yeah. Addie has it.
Under resources, I found out that Wisconsin Parkinson's is a magazine that comes out. I think it's either monthly or quarterly.
Okay, yeah. Is it the Wisconsin's Parkinson, the APDA branch of the Parkinson Society? But that's okay. In Milwaukee. Have you found that useful? A useful publication?
The last one has been.
Really, good to know, good to know. That's a good source because it's not generally drug company funded, or if it is, there's a couple drug companies, or it'll switch month to month, which, you know what I mean? So it won't be as biased. If something's produced by a drug company, guess what? They're gonna be, trying to make you have their drug, but anyway. But thank you, that's good to know.
You can get it up on a computer and you can copy the magazine.
Okay, it's on like a digital that you can download and make copies of or read it on.
Submit they would send it to you.
Okay.
What's the name of it?
I think it's the Wisconsin Parkinson's Society, so it's the Wisconsin chapter of the American Parkinson's Disease Association. Is most likely. I think that's the one that I saw one recently too. I was wondering if patients would think it was good too, because this is pretty good from my standpoint. But anyway, sorry I'm buzzing. It's a 2-mic night, like double drinking.
I just wanted to check out a couple of the things you mentioned to make sure my notes are right.
Okay.
Lifespan. I think you said it's a fairly normal lifespan.
Right.
And if we're going to die, it could just be likely from another cause.
Right. Most people that I take care of will die from something like cancer is a common one. They can have heart attack, like all that, what I call regular stuff. Now, when you look at obituaries in the paper, they'll make it sound like everybody's dying from Parkinson's disease or complications of Parkinson's disease. Remember, an obituary isn't a medical document. It's whatever the family told the funeral home. So if someone has lived with Parkinson's a long time, they might feel that, oh, well, their heart attack was a complication of Parkinson's or something. You know what I mean? So, really kind of take that with a grain of salt. I was reading the Sunday obituaries a couple weeks ago, and I'm like, gee whiz, And so that's kind of one of my pet peeves because it makes you think it's, deadly. And
Well, is it a given if you have it long enough, you're going to become disabled, end up in a nursing home, or is it not a given?
no, it's not a given. I would say the majority, and I'm talking, some people I see, they've had it a few years. Some people have had it 20 or 30 years, and you're not guaranteed to be in a nursing home. In fact, we try to keep you out of nursing homes. Maybe assisted living, like especially if your loved one that maybe you lived with might have helped you a little bit and you help them. If that person passes away and you're more by yourself, then you might need to go to assisted living, or you might have people come into your home and you have home health aides or something like that. And and it's variable. There's people who, that maybe they need to use a walker eventually, but there's some people who don't. There's some people who are in wheelchairs, some who aren't. So it's really, really variable. I can't tell you, like when I first meet somebody, or even after knowing them for 5 years or so, whether even some of my people I've known for 10 years, I can't tell if they're going to need to be in a nursing home at some point or not.
But the
So
levodopa and some of the other meds can slow that process?
it doesn't slow it down, but because we can treat the symptoms and people are staying more active and we're trying to avoid side effects, people they're just living better.
That's right.
So.
You said it doesn't wear out.
Right. You might develop some side effects and it has to be adjusted and such, but yeah. And you can develop symptoms that don't respond to the medicine, but yeah.
And what symptoms do respond to levodopa?
The stiffness or rigidity, the tremor can, not always, but can. Sometimes the slowness. Some people will feel like overall they can just get up and move better. Some people will have some walking problems that will respond. Some people will develop this where they get their feet stuck to the floor. That often doesn't respond, or might initially respond, but later on might not. But not everyone develops the gait freezing and stuff. So it's kind of like you have to take it as it comes, really. As long as you're exercising, taking care of yourself in other ways, it's a little bit, at least at this point, kind of taking it as it comes and adapting to it and finding workarounds.
And as those symptoms come, that's the guidepost for whether you need an increase in them.
Right. Yep, we don't monitor brain levels. There's no way to really do that without harming you. And the brain isn't that precise. So we can judge on your doses based on what you're telling us and what your symptoms are.
And then lastly, in terms of the meds, what's the range of levodopa? I know I'm taking half.
Mm-hmm. Yep.
I don't know what it goes
Yep.
up to 30 of them a day.
Yep, I have some people who are on a half once in a while, depending on the activities they want to do. I have other people that take, 1 or 2 tablets 3 or 4 times a day. I have some people that are taking 1 or 2 tablets, nearly every hour while they're awake. So a huge span.
My brother, before he passed away, he had a diagnosis of palsy. Was it Parkinson?
Of palsy?
Yeah.
Yeah, I've seen that term used for tremors. I've seen that term used also like if someone has a stroke and they have weakness. So that's kind of like this vague term.
His face completely, his face was distorted. So.
Oh, he might have had something called Bell's palsy, which is a facial nerve problem where his face was paralyzed. So that's kind of like an,
But that's not Parkinson's.
no, not necessarily, yeah. Yeah, that has like a lot of, that's interesting. That's like a trivia question for a neurologist. Trivial pursuit for neurologists.
So the drug delivers dopamine to your entire brain, I gather.
Mm-hmm.
Is that what happens in a normal brain?
Yeah, I mean, it's like all swimming
very
around in
different.
there. Yeah,
Okay.
yeah. I mean, because we're, giving probably at times over, like more than the brain needs, that's what we think can sometimes lead to the mechanisms that might cause those dyskinesias, the weird wiggly movements like that Michael J. Fox has developed and
Some
stuff.
parts of your brain are being too sensitive.
Right, or it screws up the receptors that are using it because it's, because it's not totally like biologic levels, but there's just no way to do that, which is why there's lots of research looking at like stem cells and, they did these fetal tissue implants years ago thinking, oh, that'll be like a little physiologic pump. Well, that was a disaster in certain cases. So we learned a lot from it, but, they're not going to be doing that again.
Can stress affect this in any way?
Of course, yes. Yep, that's a good point. So stress can affect it by, lots of different ways. Even, the stress of not getting a good night's sleep, the anticipation of a scary event or a fun event that you're excited about gets your adrenaline going. And especially if you have tremors, oh my God, they go crazy. They're like a toddler in church, acting up. And, you can't, what I believe, I don't know that there's biologic proof, but I don't think you can make your disease progress quicker because of the Parkinson's, because of stress, I mean. What the stress will do, though, is, your brain is compensating even once you have symptoms. But if you give your brain too many things to do, it's going to decompensate. And so you'll see some breakthrough symptoms. You'll unmask some symptoms potentially. So, we'll see that like before a surgery for whatever, you're just, so.
I wonder if you could mention a little bit about the role of meditation, whether it's helpful and how frequently, how long.
Yeah. Meditation is a really good thing to do for, part of the, your holistic lifestyle, and all the mindfulness stuff that's the rage is actually really helpful. I have, the exact, how often to do it. It's, I can't give you like a prescription sort of like that. But people that do know how to meditate, for example, if they have tremors, they'll feel like they're anxious, but they're not, and those tremors will get going. And I have people who are good at meditating who can sit there for after a few minutes, and they can kind of eliminate their tremors because they get in this kind of, and they're not unconscious or fell asleep or anything, And so I think that whole, mind-body connection when you're living with a chronic disease like this is very important because it puts you into the present. It helps you not worry about the future. It, and it helps you take care of yourself. And it wouldn't surprise me if there's good endorphins or whatever you want to call these trophic factors release that are helpful too. I don't have evidence of that, but I think it's, a very good thing to do. I wish I could meditate, but as soon as I try, I fall asleep. So I'm crummy at it. Maybe I should work on that.
Would you say a few words about hallucination?
Yes. So some people with Parkinson's disease will have hallucinations so they can see things that aren't there. That's what I mean by hallucination. I'm not talking about dreams at night or acting out your dreams. So this is you're wide awake and you might see, often people will see children or animals that aren't really there. And sometimes they're not threatening. They're kind of, oh, that's weird, that purple bunny or whatever. Or they see an old pet running around that really is not there. Some people can get scary hallucinations. Of course, that kind of crosses a line. But I have some people where, when they're starting to hallucinate, we'll reduce their medicines. We'll make sure the medicines aren't causing it. Also make sure there's not an infection occurring. Something as simple as a bladder infection or UTI can cause people to hallucinate. If they've recently fallen and hit their head, we might decide if we need to get some type of CAT scan or not. But the Parkinson's medicines can cause people to hallucinate too, so we might have to adjust downwards on the medicines. If that causes their movement symptoms to be worse, then we might have to add medicine to try to suppress those hallucinations. Sometimes when people are starting to hallucinate, if we can't really blame it on the medicine, that might be a sign that cognitively they might be starting to develop some memory issues too. But usually we want to make sure that a medicine isn't causing it. Even a lot of people are on Detrol or oxybutynin for bladder control, and some people that makes people hallucinate. I mean, there's, anyways, some people when they get sick, they hallucinate. So it's real individual, but oftentimes we can control it. Sometimes it can take some high-powered medicines to control it, but sometimes I have many patients who are like, oh yeah, I had a hallucination. They know what it is, and it's not frightening to them. But so that's one end of the spectrum. The other end of the spectrum is, they're seeing really scary things, and we have to intervene. Does that answer your question or give you better information? Okay. Any other comments? Anybody with advice? Advice to me so I can keep living a good life even though I have yet to develop Parkinson's. I get a lot of good, I should be doing that.
I succeed well.
Okay.
Just a little bit to the meditation thing. I found
Yes.
some really nice apps that you can download for your phone. Like, for instance, I use Relax Melodies. It's one that I use to help me go to sleep because I'm such a horrible sleeper anyhow. And then when you get all stuck and you can't move and your mind's racing 500 miles an hour and you know you need sleep and it's only going to help. So finding things like that that will help you sleep at night and just really focusing on them. And I'm usually asleep within 5 minutes of a 10-minute meditation thing. I'm not a good person for being in the moment and meditating, so it's a really helpful app.
Thank you. Yes.
Don't ever drive and listen to one of those tapes.
Good point. Yes.
One time I was coming from a meditation workshop and I
Uh-huh.
was enjoying it. I wanted to just listen to it. All of a
Yeah.
sudden I went, oh wow.
Yeah, it really worked. Yeah.
We enjoyed to hear the comment.
So she's saying don't ever drive to listen to one of those.
Those cool meditation tapes.
Because you could just go right off. And sit up and you're listening to them so you don't fall asleep.
Yeah. Go ahead.
I just wanted to ask, how does Parkinson's affect like driving ability?
Yeah, it's again very individual, and it's always a dilemma to tell someone that they shouldn't drive, and in a way, it's the easy way out for the doctor, right? Because oh gosh, you're having a little trouble walking, maybe you shouldn't drive. The family, oh, you don't have to worry, but it's very disabling to do that to somebody in our society and where we're living. So I try to not do that, but I want people to be driving safely, obviously. And so it's, it is a tough thing because I have people who, they have terrible gait freezing. So there are these people who are like stuck. Well, if they're sitting down, their legs work just fine and they can actually drive. Now, they might drive to the mall and not be able to get out of their car, but they can still technically, drive. So it is, it's really individual. The thing that usually limits driving even more so, because people usually will self-limit. They'll start to become uncomfortable, and so they'll start to limit their driving. However, if people are having significant cognitive problems, they might lose insight, and that's where we normally have to intervene. There's research articles that come out every few years saying, oh, their reaction times are different and all this kind of stuff. And it's like, well, yeah, if you put them in a simulated, non-natural environment, they might not score quite as well. But yet, if they're an experienced driver and the squirrel runs out in front of the car, chances are they're going to put the brakes on pretty quick. It's like automatic. And but it is, those people often themselves will self-limit, so it actually is something we deal with a fair amount, but, it's really not too often where I have to be the mean one to say, yeah, you better not be driving, and, so, yeah. So another wishy-washy answer that we have to, address with the person, that's really one of the big messages here, is that it's a very individual thing. Right.
Evaluate that. The question was, how does Parkinson's affect driving? And so that's what she was talking about. And just to follow up, oftentimes occupational therapy can help people know if they're, safe to be driving.
Yeah.
You guys hear okay?
Yeah, I have to remember to repeat the question. I'm terrible at that.
Sorry.
Yes.
This is not just about Parkinson's, but it's about aging as well. And occupational therapists are like one of the best
Yeah, she's saying how occupational therapists are a godsend. They can help you with the, she used the example of bending over, putting your sock on. I mean, just little tricks and things that they're there to tell you about, and very valuable. And they're nice people. I've yet to meet a PT, an OT, or a speech therapist who is not nice. Now, sometimes they'll seem like, like you're in the military, like really, but they're nice people. Any other questions or comments? Alrighty. Well, if you do have other questions, I'll try to hang around a little bit. You can get this presentation, the slides and stuff online. All you have to do is search, UW Health moving forward, and you'll come up to some links. So like if you want, copies of like some of those comments and the slides and stuff, they'll be on there. It's a good place to look. Okay. All right. Well, thank you. Thank you for your attention.